we will start this conference once again to make sure our international audience gets everything in both languages. What's going to happen now? So, could you give me the first slide, please? That today we are part of a unique project called the Menopause Hour. This is a project with the Russian Society of Specialists for Gynecological Endocrinology and Menopause as part of the Council of Affiliated Menopause Societies. This event will be broadcast in Russian and English. Today, we will talk about the hottest issues of menopausal hormone therapy, and we'll have two speakers today. Nick Panay, the legendary past president of the International Menopause Society and a global opinion leader on gynecological endocrinology, menopause, and premature ovarian insufficiency, which will be the topic of his talk. And there will be my presentation on MHT and breast cancer, and I am Antonina Smetnik, president of the Russian Society for Menopause and Gynecological Endocrinology. This is a project supported by Abbott. Abbott was not given the power to choose speakers or topics, and Abbott has not reviewed or in any way modified the presentations. Please visit the website of Rosgam to find out more about the educational initiatives and resources and about how to become a member of the IMS. You will get free access to a lot of resources like exclusive offers for IMF members and for people who complete in part 1 year free of IMS membership and various offers from regional societies affiliated with the IMS, monthly live events, a library of resources, and more, which you will find on the website. The 20th Global Congress on Menopause, organized by the IMS, will be held in Brazil, in Rio de Janeiro, in 2026. Please visit the website to get more information about that. And now, I'd like to once again introduce to you the legendary Professor Nick Panay, who is professor at Imperial College London and the Chelsea Hospital, the past president of the IMS and the director of the International Center for Endocrine Health in London. His talk will center around POI, premature ovarian insufficiency. Nick, a very warm welcome to you. You have the floor.
Thank you so much, Antonina. I hope everyone can hear me clearly. Thank you to the Russian Menopause Society. It's an absolute pleasure and privilege to be with you today. And what I've been asked to share with you in the next 20 to 25 minutes is the work that we have done to update the ESHRA guideline on premature ovarian insufficiency. And you can see here my colleagues on behalf of whom I will be giving this presentation. And these are my declarations of interest. So you will see here the 2015 and 2024 versions of the ESHRA POI guideline. The guideline was updated as part of a collaboration of ESHRA with Monash, ASRM, and the International Menopause Society. A big thank you to all those involved in the guideline development. These are some of the members of the guideline development group that you can see here. My co-chair was Professor Amanda Vincent from Melbourne, and the steering committee was chaired by Professor Richard Anderson from Edinburgh. Natalie Vermeulen was our senior research specialist, and she did a lot of the work with the searches and synthesis of the data. And you can see also here the collaborating stakeholder organizations. I would like to emphasize that we included women with lived experience of POI, both in the stakeholder surveys and also 2 representatives on the guideline development group. So this is a summary of the guideline development. Just running through it very briefly, you can see that we composed the new GDG. We revised the key questions following the stakeholder surveys. And then we updated the literature searches and wrote the summary of evidence, which we then disseminated to the stakeholders for feedback. 425 stakeholder comments were received from 23 reviewers, and 2/3 of the comments on content resulted in adaptation or correction of the guideline text. So we had then to submit, after reformatting the guideline, to the ESHRE executive, who then approved it for publication. And please bear in mind that an integrity assessment was conducted for the randomized clinical trials on premature ovarian insufficiency. So the scoping survey was conducted to ensure that the key questions were still relevant. More than 75% of women and healthcare professionals considered the previous POI guideline key questions as relevant, and we ended up with 40 key questions in total. These are some of the additional questions which were included as requested by health professionals in orange on autoantibody testing and the use of anti-Müllerian hormone, and both by health professionals and women on fertility preservation, lifestyle management, non-hormonal therapies, and risk factors for POI. These are the sections of the guideline that we ended up with, which included additional information on lifestyle, AMH, and also muscle health. We use the grade system for formulating the recommendations as per ESHRE methodology. Now, it's important to recognize that the strength of the recommendations were based not only on the levels of evidence, which varied from very low through to high quality, but also on other aspects such as benefits versus risks, values that patients and clinicians applied to these recommendations, the feasibility of implementing them, acceptability in each region and country, and also the resources that would be required to implement them. And we formulated 145 recommendations. Clearly, I won't have the time in the next 20 minutes to cover all of these, but what I've done is chosen some of the key recommendations to give you a flavor of the new guideline, and then I will direct you to sources for further information where you can download the guideline as a whole, and also the summary documents. So, going through some of the key recommendations, what should this condition be called? I noticed that in some of the promotional materials, it was still referred to as primary ovarian insufficiency, but we prefer the term premature ovarian insufficiency because this reflects that it can result from external effects of chemotherapy, radiotherapy, etc., not just a primary defect with the ovary itself. It's a condition that's defined by loss of ovarian activity before the age of 40, characterized by amenorrhea or irregular menstrual cycles with elevated gonadotropin levels. Early menopause is menopause occurring before the age of 45, but above the age of 40. And although early menopause is outside the scope of the current guideline, the evidence and recommendations may be relevant to women with early menopause. And in fact, I like to think of early menopause and premature ovarian insufficiency as a continuum of risk. And I think, as I say, a lot of what we say for POI also applies to using treatment in women where we want to avoid the complications of early menopause as well as POI. Now, the prevalence, this is something that we reviewed very carefully because many of the previous studies suggested that the prevalence of POI was approximately 1%. But this was in older studies, and more recent publications have shown the prevalence to be around 3.5%, particularly in low and middle income countries. So it's quite clear, I think, as we discover more and more about POI, that population characteristics such as ethnicity may affect the prevalence of non-iatrogenic POI. The prevalence of early menopause seems to be around 12%. So these are not rare conditions. These are actually quite common conditions that can have a profound impact on individuals and society as a whole. So it's very important that we take them seriously and manage them effectively. Of course, if we look at the symptoms as a whole, they're too numerous to mention and do include hot flushes and sweats, which is typical of menopause at usual age. However, we did see a lot of women with mood swings, insomnia, sexual problems, and fatigue, for instance, where vasomotor symptoms were not the primary complaint. So it's very important that we remain alert to the fact that there may be other symptoms. Bear in mind that symptoms may be intermittent due to fluctuating ovarian function. They may vary in severity depending on the different underlying causes of POI, and some women with POI, particularly in the younger age cohorts, may not experience any symptoms, particularly those with primary amenorrhea. So what investigations should we perform for women with a potential diagnosis of POI? Well, of course, we need to take history into account, the history of amenorrhea or irregular menstrual cycles. Typically, there would be a history of at least 4 months of amenorrhea, and there should be an elevated FSH concentration of over 25 international units. One of the fundamental areas where this guideline differed from the original guideline is that FSH assessment only needed to be performed on one occasion if it was thought that this was diagnostic of POI. It only requires repetition after 4 to 6 weeks if there is diagnostic uncertainty. And the other thing to bear in mind is that if there is some menstrual irregularity still, the blood test does not have to be timed to a specific day of the menstrual cycle, because in physiological cycles, it is not likely that levels of FSH at any stage of the cycle would be above 25 international units. What about anti-Müllerian hormone? So this should not be used as the primary diagnostic test for POI. The guideline group recommended that it could be useful, however, to confirm POI diagnosis where FSH results are inconclusive. However, it's clear from the evidence that we reviewed that you cannot check AMH to predict POI occurring in 10 to 15 years' time. And therefore, at this stage, we should not use this as a primary predictive test for POI, although you can detect reduction in ovarian reserve, of course. So what's the known causes of non-iatrogenic POI? How should they be investigated? Well, of course, it's very important that women are counseled that there may be genetic causes of POI. The standard testing has involved chromosome testing, particularly looking for Turner syndrome, and also genetic testing for Fragile X pre-mutation. However, more and more centers are now able to offer next generation sequencing to detect additional genetic problems, such as those genes affecting meiosis, mitosis, and ovarian development. And it's very important that where these tests are available, that they are offered to patients. But we must also be mindful that in many countries, these tests are still not available. The data that we have from many studies now are that there are an increasing number of women that are given a genetic diagnosis, not a diagnosis of idiopathic POI, which is where we don't know what the cause was. The other thing to bear in mind is that even women in their late 30s should have genetic testing, because you can get cases, for instance, of mosaic Turners that present late with POI. So what about antibody testing? I think it should be mandatory to test for 21-hydroxylase antibodies for adrenal insufficiency, because this is one of the more common autoimmune conditions associated with POI. We should screen also for thyroid function, but thyroid peroxidase antibody screening is not that reliable because you can get false positives. I think the key test there should be TSH. Also unreliable is the screening for anti-ovarian antibodies, because again, there's quite a high incidence of false positives. One of the things that women complain about in how the diagnosis of POI has been conveyed to them is that it's not conveyed in a sufficiently compassionate and sensitive manner. So I think it's really important that we counsel them very sensitively about this really important diagnosis, and provide them with personalized evidence-based information about the condition to ensure that they fully understand it and also have the opportunity to ask questions. And it's important that we refer to appropriate support groups. We have one called the DAISY Network in the UK, and also mental health care professionals, because there is a high incidence of psychiatric morbidity. So this is one of the reference slides, which I'm not going to go in any great detail, which shows an algorithm for diagnosis of POI. We need to ask about chemoradiotherapy to see if it's iatrogenic, ask about genetic testing, ask about autoimmune testing, and of course, if they've had bilateral oophorectomy before 40, this automatically puts them into iatrogenic POI. You will be able to see these reference slides in more detail in the papers that I'm going to signpost to you at the end of the presentation. What about life expectancy? Unfortunately, POI reduces life expectancy if it is not treated appropriately. This is largely due to cardiovascular disease, but also due to other problems such as bone and cognitive problems. It's very important, therefore, that hormone therapy is recommended until the usual age of menopause for primary prevention purposes, not just to treat symptoms. Whether women continue with hormone therapy from the age of 51 onwards, which is the average age of menopause, should be decided on an individualized basis. And of course, every woman should be advised about avoiding smoking, minimizing alcohol, having a healthy diet, regular exercise, and maintaining a healthy weight range. Fertility interventions. I'm sure this group need no reminder that many women are pointed in the direction of unproven fertility interventions like stem cells and platelet-rich plasma, but the guideline group felt very strongly that we should convey the message that there are no interventions that have been reliably shown to increase ovarian activity and natural conception rates with autologous oocytes. However, women with POI can be informed that oocyte donation is an established option to achieve pregnancy after a diagnosis of POI. But if they use their sister's gametes, then they need to bear in mind that they could be sharing genetic risk, which then could be carried to their offspring. And it is also associated with a higher risk of ovarian stimulation cycle cancellation. In terms of bone protection, osteoporosis risk factors should be identified and addressed at POI diagnosis. I've talked about the lifestyle measures which should be introduced, and there should be adequate doses of hormone therapy containing at least 2 milligrams of estradiol or 100 micrograms of transdermal estradiol. Delayed initiation and non-adherence of estrogen therapy should be avoided. And if a combined oral contraceptive pill is used, then a continuous or extended regimen is recommended to avoid bone loss In those women contraindicated to hormone therapy, there should be work with an osteoporosis specialist to advise on non-hormonal treatment options. From the cardiovascular perspective, we know that women with POI have an increased risk of cardiovascular disease, including coronary artery disease, heart failure, and stroke. We know that hormone therapy has beneficial effects on cardiometabolic risk markers, even though we lack long-term prospective randomized clinical trial data. But the GDG felt strongly that women with POI should have hormone therapy to reduce cardiovascular morbidity and mortality. There should be monitoring of cardiovascular risk factors like lipid profile and diabetes screening, which should be the frequency of which should be based on the presence of other risk factors, including hyperlipidemia, hyperglycemia, and also global cardiovascular risk factors. What are the management options for the effect of POI on sexuality? So POI has a profound effect on sexuality, and we recommend a biopsychosocial approach to managing this. And where available, transdermal testosterone therapy should be offered as an option in women with distressing low libido, which we refer to as hypoactive sexual desire disorder. It's important that women are given physiological doses of testosterone in order to avoid adverse effects such as excess hair growth and acne. Neurologically, we know women with POI are potentially at an increased risk of cognitive impairment and dementia, and the possible effect on these risk factors is accelerated by bilateral oophorectomy, not just below the age of 40, but below the age of 45. So once again, it's important that hormone therapy is used in these women in adequate doses and duration to avoid these problems. In terms of the types and indications for hormone therapy, we've said what the indication is to minimize morbidity and mortality. And it's also important to discuss whether continuing hormone therapy beyond the age of average menopause is going to be beneficial for that individual. Remember that most types of hormone therapy do not provide contraception unless, for instance, the hormone therapy includes endometrial protection with a levonorgestrel intrauterine system. Hormone therapy in this age group does not increase the risk of breast cancer compared to women of the same age group without POI, and I'm sure that Antonina will talk about this more in her presentation. Hormone therapy is not recommended in women with a history of breast cancer, but women with the BRCA1 and 2 mutations without a personal history of breast cancer can be advised that hormone therapy is an option after risk-reducing BSO, and certainly for the first few years, there's no evidence that that attenuates the benefits of risk-reducing BSO. Of course, we should give a progestogen as well as estrogen in women with an intact uterus, and the dose of progestogen should be increased when the dose of estrogen is increased. Once again, this table is for reference, but suffice to say that we start, generally speaking, with higher doses for women with POI, but if they have side effects, then we can start slower and then build the doses up, because there is a dose response effect in terms of symptom control and also protection of their skeleton. We tend to prefer micronized progesterone or dydrogesterone for endometrial protection. And we can start with a sequential combined regimen and then switch to a continuous combined regimen. But of course, the global challenge is that there isn't universal availability of hormone therapy regimens. And in low and middle income countries, for instance, in sub-Saharan Africa, women, I'm told by specialists that work in that area, can have a BSO performed without hormone therapy being available for them. We should also be mindful of these compounded varieties of bioidentical hormone therapy, which are not entirely evidence-based. And just finally ending with puberty induction, this should be progressed using 17-beta estradiol. It's unclear whether oral or transdermal is better, but what is clear is that the oral contraceptive pill should not be used for puberty induction because it doesn't lead to sufficient uterine and breast development. And after a couple of years of estrogen therapy, we should introduce a cyclic progestogen. Once again, this is for reference. This is a management algorithm, just to remind you of the history and examination and investigations that need to be performed, and that we should provide information on lifestyle, psychological health, fertility, systemic hormone therapy, bone, heart and brain health, sexual function, and also genitourinary symptoms. And don't hesitate to prescribe vaginal estrogen as well as systemic estrogen in women with persistent vaginal symptoms. So this is my last slide. I'd like to say thank you for listening, and I'd like to signpost you to the full guideline, which is now published on the ASRM, ESHRA, Monash, and IMS websites. The summary papers are co-published in Human Reproduction Open, Fertile, Sterile, and Climacteric. There are educational tools for healthcare providers and the public, including POI infographics, algorithms, an Ask Early Menopause app, and we're developing slide sets as well. You can see a list of the conferences that we will be presenting the guideline at and have already presented it. And also, we presented a webinar earlier this year on behalf of IMS, where we had over 1,000 registrants, and we have a Women's Health Partnership Symposium planned, which will be a collaboration between ESHRA, SRM, Monash, and IMS in July, so next month. And then research projects are ongoing in order to update the guidelines with further data. There's a randomized clinical trial of pill versus hormone therapy in the UK, and also a registry which we're about to relaunch at poiregistry.net. So that I'd like to say spasiba bolshoi, thank you for listening, and I look forward to sharing some questions and answers with you.
Dear Professor Nick Panay, thank you very much for this brilliant talk. You presented very, very important data, and I believe we are already having questions, but as we agreed in the very beginning, there will be a time for Q&A in the end of today's menopause hour. So I will be the next speaker, Antonina Alexandrovna Smetnik, the head of the Endocrinological Gynecology Department at the Kulakov Research Center in Moscow. The topic of my talk is going to be menopausal hormone therapy and breast cancer. Here you can see my disclosure. There may be a perceived conflict of interest, but I was absolutely independent in crafting this lecture. Breast is a target organ for a lot of hormones and growth factors, with estrogens, progesterone, androgens, prolactin, thyroxine, insulin, growth hormone, glucocorticoids, mineralocorticoids, and even vitamin D, they all play a role. In the early 2000s, a lot of people rejected MHT because of fears induced by the first results of WHI. WHI appeared to show that combined hormone therapy increases the risk of breast cancer. Let's now look what actually WHI has shown. A certain combination of an estrogen and a progestogen, combined equine estrogen and medroxyprogesterone acetate, did increase the risk of breast cancer, with the relative risk 1.26. It's less than +1 case per 1,000 women years. And it's very important to understand that medroxyprogesterone acetate has not just a progestogenic action, but also androgenic and glucocorticoid action, which does have an impact on the risk of breast cancer. According to the follow-up analysis, prior non-users of MHT who started using MHT only in this trial, their relative risk against the overall background was 1.09. And importantly, hysterectomized women who only took estrogens actually faced a lower breast cancer risk. So their relative risk was 0.77. Of course, more than 20 years fast forward, we now have enough evidence after more than 20 years of follow-up. There were a lot of analysis and reanalysis of those primary data. And so what we know now that even the people who took this problematic CEE plus MPA combination with statistically significant increase in the BC risk, those women did not face actually a higher risk of death from breast cancer. And actually, if we look at the users of CEE, they statistically significantly reduced both incidence and death of breast cancer. There are several other trials to consider on top of WHI. For example, the E3N French cohort study and registry study from Finland. These two studies have demonstrated that estrogen in combination with dydrogesterone or micronized progesterone does not statistically significantly increase the risk of breast cancer. Here you can also see the data of another big research work by Jana Vinogradova from the UK. She looked at the data from more than 98,000 women aged 50 to 79 with a primary diagnosis of breast cancer, with more than 457,000 matched controls, women without breast cancer. So according to her generalized assessment of the risks of estrogen therapy plus various progestogens. So what she shows is that there is no increased risk from short-term use up to 5 years of estrogen only, estradiol dydrogesterone combination, or tibolone. So while generally longer-term use may be associated with the increase in the risk, estradiol dydrogesterone combination and tibolone demonstrate the smallest risk increase, while synthetic progestogens demonstrate a higher increase of the risk. So this is what the IMS guidance now says. The possible increase in breast cancer risk related to MHT is less than 1.1% per annum, or an incidence of less than 1 case per 1,000 women per year of use. And this, it is important, it is similar or lower than the increased risk associated with common lifestyle factors, such as reduced physical activity, obesity, and alcohol consumption. Also, data from the WHI demonstrates no increased risk in first-time users of MHT during the 5-7 years since initiation of treatment. CEE monotherapy demonstrated during 7 years of use that it actually decreases the risk of breast cancer diagnosis and mortality in hysterectomized women. And the increased risk of breast cancer is primarily associated with the addition of synthetic progestogen, MPA, and related to the duration of use. The risk may be lower with micronized progesterone or dydrogesterone than with a synthetic progestogen. The risk of breast cancer attributable to MHT is already low and is even lower with the duration of use. Breast cancer survivors is a little different. The use of systemic MHT or tibolone is generally not advised in survivors. Observational studies and randomized trials report both neutral effects and increased risk of breast cancer recurrence. For survivors of breast cancer, decisions about systemic or low-dose vaginal HT, for example, according to the American Menopause Society, it can be indicated for compelling reasons after non-hormone or complementary options have been unsuccessful and after detailed counseling with shared decision-making in conjunction with an oncologist. Treatment of GSM in women with breast cancer can be complemented by adjuvant treatment, AIs or tamoxifen, which lower estrogen concentration or antagonize estrogen effects, product labeling, limited clinical data in patients with breast cancer or survivors, and of course, there may be just absence of agreement between oncologists and other practitioners involved in genitourinary and sexual healthcare. For persistent symptoms, topical lidocaine, low-dose vaginal ET, DHEA vaginal ospemifene, or laser therapy, they can be indicated. Estrogens, vaginal, are contraindicated according to FDA class labeling. However, off-label use of several products may be acceptable because of their very low systemic absorption. However, distinguished colleagues, we need to remember that in the Russian Federation, estrogen-containing medicines and DHEA just cannot be indicated to women with breast cancer because according to the Russian label, there is a direct contraindication. Breast cancer survivors frequently suffer from iatrogenic or premature menopause due to adjuvant chemotherapy or endocrine therapy. And this has coincided with an increased burden of vasomotor symptoms, which have been demonstrated to have a detrimental impact on quality of life. Importantly, iatrogenic side effects are strongly correlated to non-adherence to adjuvant therapy. I have a patient and she had told me that she was taking tamoxifen not daily but every other day, and she would not tell her oncologist because she has very heavy hot flushes. Thus, controlling these troublesome systems remains a pressing issue, as well as long-term benefits of estrogen for osteoporosis and cardiovascular disease. 4 randomized controlled trials have evaluated MHT in breast cancer survivors, and all of these trials reported increased rates of disease recurrence with MHT. However, data from 16 observational studies reported no increased risk of recurrence with MHT. According to Trin et al., only 5% of physicians were willing to prescribe MHT to breast cancer survivors with severe menopausal symptoms after the first results of WHI. So these studies highlight that whilst the burden of menopause is great, the fear of recurrence is greater. In 2022, eligibility criteria for MHT were published. They were published by a work group chaired by Nicolas Mendoza from the Spanish Menopause Society. So in this publication, you can see that the hormone-dependent breast cancer has the 3rd category for monoestrogenic therapy and for combined therapy, with category 4 for Tibolone. But for triple-negative breast cancer, the eligibility criterion is 2, which means that benefit may actually be greater than the risks. But again, in Russia, you've got to refer to the clinical guidance. And at this moment, this is a direct contraindication unless there is an exception which requires a cross-functional consilium here in the Kulakov Center in Moscow for each case. Lancet published a review of systemic MHT in women with cancer in 2024. So MHT should be avoided, systemic MHT should be avoided, but if the breast cancer is ER negative, in specific subgroups of patients, hormonal therapy could be considered. There is data on more favorable histologic features if the patient has identified breast cancer during the use of MHT. Normally, these tumors are smaller and they proliferate slower than non-users. Of course, a confounding factor in these studies is that hormonal therapy users are more likely to have mammograms and diagnostic tests, which means that they are diagnosed earlier and therefore they die from this cancer rarer. A large study using a Finnish registry reported a reduction in breast cancer mortality in MHT users. Also, I provide data from 2024 with data from 160,000 participants were analyzed with self-reported MHT use. And according to that study, MHT does not decrease the survivability in breast cancer women. The IMS and the Russian clinical guidance both say that breast cancer risk always should be evaluated before MHT prescription. The breast cancer risk should be considered increased in women with a family history of breast cancer or a personal history of breast biopsy. And also, this is the same for women with a history of Hodgkin lymphoma treated with mantle radiation. There are several tools you can see in the slide that can help with the assessment of breast cancer risk. However, there is no universally recognized cutoff for high risk. If the breast density is high, mammography interpretation is difficult. And according to IMS, women who use MHT should not do mammography more frequently than others. But if an MHT user has a really dense breast, mammography could be considered annually. However, in Russia, annual mammography is indicated to all MHT users. There is no additional risk of breast cancer in women with aggravated family history or BRCA positive or BRCA positive or those with bilateral ovarioectomy. However, they are at higher genetic risk, primarily ER negative, and they need to go through the risk reduction procedures. Of course, you can partly compensate the general increase in the BC risk by selecting women with lower individual baseline risk, BioRads category 1 or 2, low breast density, especially if you consult an oncologist first, and of course by providing education about reducing body weight and increasing physical activity. And there are no reasons to think that oral versus transdermal are better or worse in terms of the breast cancer risk. Dydrogesterone or micronized progesterone have a lower risk increase than synthetic progestogens. Currently available data imply no difference in risk between oral transdermal in trials up to 2 years duration. Breast tenderness, breast density, and breast cancers were not increased, and we have seen the data from Yana Vinogradova about tibolone, about dydrogesterone, estrogen, and estrogen only, not resulting in risk increase, and dydrogesterone EPT therapy for 5 to 9 years associated with a smaller risk increase than other EPT combination. There is also a meta-analysis published in 2024, which has shown that 10 randomized trials show that monotherapy by estrogens decreases the BC risk. And we all remember this meta-analysis in The Lancet, Type and Timing of Menopausal Hormone Therapy and Breast Cancer Risk. It showed that if a woman starts MHT use at an age of 50 and continues for at least 5 years, then 1 in every 50 users of estrogen plus daily progestogen preparations, 1 in every 70 of estrogen plus intermittent progestogen preparations, and 1 in 200 monotherapy estrogens increase the risk. However, right after that publication, we got a joint statement on the leading menopause society on MHT and breast cancer risk. And these societies said that no arbitrary limits should be placed on the dose or duration of usage of MHT. The decision should be based on it should be based on evidence, and diagnosis should not be made in isolation. So if we stratify the risk of breast cancer, this is like a traffic light. The red light is personal history of breast cancer, especially hormone receptor positive. You need to consider it very carefully if she has a history of atypical hyperplasia or carcinoma in situ on breast biopsy, if there is a history of Hodgkin lymphoma treated with mantle radiation, BRCA1 or 2 mutation carriers before bilateral oophorectomy to reduce risks. And there should be an estimate 5-year risk of more than 1.67% or greater of a lifetime risk of more than 20%. And green is BioRes assessment category 1 or 2, low density breasts, and no other risk factors. Type, dose, and duration of MHT should be considered. Lifestyle measures should be recommended. And of course, this decision should be individualized, shared decision-making, and the personal risk-to-benefit ratio should be re-evaluated regularly. Oncological risks in case of correctly selected patients and MHT are low or very low. However, there are exaggerated fears. Risks largely depend on the composition of the drug as well as on the individual benefit-risk ratio. Correction is possible both at the start and during MHT intake. In the presence of indication and in the absence of contraindication, as well as in case of timely start, the benefits of prescribing MHT in relation to overall mortality prevail over possible risks. And MHT rejection, hormonophobia, because of MHT-related cancer fear, can negatively affect, actually, the health, quality of life, and life expectancy of a woman. Distinguished colleagues, thank you very much for your attention. Now, we will have a Q&A session. I can see that a lot of people have already sent their questions. So I'd like to have Professor Panay right now. Thank you very much. And we will pass on to the questions. All right, with your indulgence, I will read it out, the first question. So Andrei from Voronezh is asking, what drugs do you use for hormonal contraception in a POI woman? Which drugs are preferable and which regimens are preferable? What do you say to this, Nick?
Thank you very much for that important question. I would like to preface my answer with a statement that in the past, the use of the contraceptive pill for POI has been often driven by practicalities rather than science. Practicalities such as requirement for ongoing contraception, despite the diagnosis of POI, because we know that there can be a chance of pregnancy still. And also because younger women want to feel like their peers, like the people in their age group, who are also using the pill. So I think we need sort of better research. And this is one of the rationales why we're doing the research in the UK, looking at outcome measures of pill versus hormone therapy, primarily looking at bone mineral density after 2 years of usage. Now, if the pill is going to be used, then we typically need to think about using standard doses of ethinyl estradiol, so 30 microgram pills, rather than the low dose 20 microgram pills. And ideally with better progestogens like drospirenone rather than norethistron or levonorgestrel. And also avoiding the 7-day hormone-free interval. Some pill regimens are now in a 24/4 regimen, but even then, skipping the hormone-free interval to use the pills back to back. There is some question as to whether we should move towards using estradiol, 17-beta estradiol pills or S-tetrol pills in women with POI. And we do have a number of options for those now available in many countries. The concern is that perhaps the doses of estradiol or S-tetrol are not high enough for these young women with POI. But I do think that they are a reasonable option, and particularly for those women who have side effects with the adverse effects with the ethinyl estradiol pills. I think we can consider the estradiol or S-tetrol pills. So I don't want to go into any specific brand names because that will vary from country to country, but I think those are the principles upon which we prescribe the pill for POI.
Thank you very much. Thank you very much, Professor. There is another question. It's also about contraception in a POI woman. What happens if the woman already is taking HRT? Does she need to take anything specifically for contraception purposes?
Yes, as I indicated in the guidelines, it's important that standard hormone therapy regimens are not thought or recommended to be contraceptive, because ovulation can still occur spontaneously. And in fact, there is some evidence that women starting hormone therapy with POI might even have an increased chance of pregnancy because it reduces the FSH and LH levels, which may be downregulating and prematurely luteinizing follicles. Now, clearly, for those women who do require contraception but want to use HRT, then they can use a levonorgestrel intrauterine system. I will mention the brand name because it's almost universal. It's a Mirena. There are other levonorgestrel systems as well. And I also mentioned these estradiol delivering contraceptive pills, which are more like hormone replacement therapy. In fact, there's very little difference. So those could potentially be used where contraception is required, but it's felt that either the woman wants to use more natural type hormones, or it's felt that metabolically it may be advantageous for her.
Thank you very much. Another question. How do combined oral contraceptives impact the ovarian reserve? Can the use of COX help in preserving the ovarian reserve in a woman?
Look, to answer the last part first, whilst logically one might think that by preventing the recruitment of follicles and ovulation on a monthly basis, there would be protection of the ovarian reserve. There's very little evidence to actually prove that, but what we can say is that it does not affect ovarian reserve in a bad way. So the ovarian reserve continues to be what it would have been if the woman was not using the combined oral contraceptive pill. However, sometimes there is confusion because perhaps a woman has her anti-Müllerian hormone levels checked when she is on the pill. And there is some evidence that by suppressing follicular development, that AMH levels are about a third lower in women using the pill. There may be some concern that this is adversely affecting her ovarian reserve. There's also concern that we used to talk about post-pill amenorrhea, that this phenomenon where the periods are delayed to start after coming off the pill. But this is more likely because there was an underlying condition or a problem such as hypothalamic amenorrhea or polycystic ovarian syndrome, which delayed the periods starting anyway. It's not because of an effect of the pill itself. So I think we can be reassuring to women that there is no evidence that there is an adverse effect on ovarian reserve with the pill, but there may be a little bit of suppression of the AMH, and this usually recovers after the first 2 or 3 months of coming off.
Okay, thanks. Next question. What is the strategy if a woman has POI and endometriosis? For example, she has undergone surgery for endometriotic cysts and it resulted in primary ovarian insufficiency. How do we manage such a patient without fearing recurrence of endometriosis?
I think for these women, it's important that they go immediately onto no bleed or continuous combined hormone therapy regimens or the continuous use of the pill. And if anything, this should have a protective effect against recurrence of endometriosis. The other question we're often asked is if they've had a hysterectomy after endometriosis diagnosis and ovaries removed, do they require progestogen as well as estrogen? And the answer is usually yes, unless it was thought to be very mild and it was all removed at the surgery. We would normally recommend the concomitant use of progestogen with estrogen even after hysterectomy. And the important thing is to make sure that they use adequate doses of progestogen to suppress any residual endometriosis that may be present, either if they've had surgery or not had it. If we're increasing the dose of the estrogen as we use higher doses in POI, it's really important that we also simultaneously increase the dose of the progestogen. And this is, you saw the reference table in my presentation. I think that's a very good starting point for these continuous combined regimens. The other possibility, which works very well if they've not had a hysterectomy, is to insert levonorgestrel into uterine system, which will give very good protection of the uterine lining and also suppress endometriosis. We know that the levonorgestrel distributes very quickly throughout the pelvis, even though its primary action is local. So that would be another good combination.
Thank you. Just to continue to pick up on this question, we have another one. So let's imagine such a woman And do we prescribe the amount of gestagen, which would be the same as for a woman in perimenopause, or should we increase the dose of the gestagen compared to just a woman in perimenopause? And if we use the intrauterine system with levonorgestrel, how many presses of estrogel should be maximum? So can we do this with together with levonorgestrel?
Can I ask for clarification? Is this for women with endometriosis or women with POI in general?
Endometriosis.
Yeah.
Endometriosis.
Okay. I think it's okay to start with a standard regimen that we would use for perimenopause or early menopause or menopause at the usual age, but not to hesitate to increase the dose of the progestogen if there is bleeding or pain. Remember that some women are progestogen intolerant, so we have to be a little bit careful about giving them too much progestogen to begin with relative to the dose of the estrogen. But I have very little concern about the dose of estrogen when a Mirena, when a levonorgestrel system is used. So the standard regimen is 2 to 4 pumps per day. With women with POI, it's quite often that they are on 3 or 4 pumps a day, maybe even more. The Mirena, the levonorgestrel system, should be quite sufficient to adequately protect against endometrial hyperplasia and also recurrence of endometriosis.
Thank you. If a woman has a POI diagnosis at an early age, and she would need to take hormonal therapy for at least 15 years to the age of menopause, is this really safe?
So thank you for this question. I think it's one that Antonina can also contribute to. As I said in my presentation, the replacement of hormones at the usual dose is safe for women with POI because we are just replacing hormones which would have naturally been there if their ovaries were working normally. And in fact, they are probably receiving less hormones than their ovaries would have produced spontaneously. We have to be a little bit cautious because we lack long-term prospective randomized clinical trial data to prove that, but the observational data for women with POI are very reassuring. There is a little bit of a gray area as far as early menopause is concerned. The collaborative group produced some data that the risk of breast cancer may be higher in women with early menopause using hormone therapy, so above the age of 40, below the age of 45. But they were comparing the data to women not using hormone therapy at all. They should have compared it to age-matched women whose ovaries were working normally, because you would not deny somebody hormone therapy who's had early menopause. Because of the effect it has not only on their quality of life, but we know early menopause can also impact the bone, cardiovascular, and cognitive functioning. So please don't worry about the duration of use of hormone therapy in women with POI. It does not have the same relevance as women who extend their lifetime exposure to hormones from the average age of the menopause. That's a different scenario. And I'm sure that my co-chair will have a view on this.
Thank you, Professor Panay. Of course, I absolutely agree with this point of view. We have another 3 questions if you have time. So
Of
first,
course.
if the patient has a diagnosis of POI at an age of 30, and she has not taken any hormones for 15 years, so we have found it out at 45 years old. So what would you think we would need to do to first examine her thoroughly at 45, and what are the options that we could offer her?
I think it's very important, and this was mentioned in the question, that we have to look at the individual's risk factors. So one risk factor is that she had premature ovarian insufficiency, uh, but where does she find herself now? We need to assess her metabolic risk, her bone risk. Ideally, she should have a DEXA scan. We should look at her lipid profile. We should do an HbA1c. But even if she went through the menopause at 30, and we've seen her 15 years later, she's still only 45. She's still younger than the average age of menopause. So I would offer her hormone therapy, at least until the average age of menopause, but you may wish to continue it further into her mid 50s or late 50s, depending on what her risk factors are that we've identified. Of course, if she has complications, she has cardiovascular disease, for instance, then we have to take that into consideration as well in our prescribing. But no, I would treat this patient with hormone therapy if she was happy to use it.
Thank you for this. Next question. Do you have any experience in prescribing to POI patients who already use HRT if they complain about VVA or sexual dysfunction? Have you experience indicating vaginal estrogens or vaginal DHEA to these patients?
Thank you. I think that's a very important question. I think, as I mentioned in my talk, it's very important that we consider the need for vaginal estrogen or vaginal DHEA in women receiving systemic hormone therapy. This applies to women at the usual age of menopause as well. Sometimes there is a concern about giving the vaginal estrogen because people worry about the dosage and whether if we give that as well as systemic, that we may give them too many hormones or too high a level. But it's very important to recognize that vaginal estrogens or DHEA are very, very low dose. The mechanism of action is local, not systemic. And if you did want to quantify the effect, one of the typical preparations which is used is 10 microgram estradiol tablets that are inserted vaginally, going under the name of Vagifem. 1 year of that preparation is equivalent to less than 1 day of systemic hormone therapy. So don't hesitate for women with persistent genitourinary symptoms to give them a vaginal estrogen. They will very much thank you for it.
Thank you. And the last question then. Until which age would you recommend taking menopausal hormone therapy, and until which age is it generally recommended in the UK?
Again, clarification, is this for women with POI or women in general?
If possible, could you please give two answers for POI women and generally for the general population of women.
So women with POI, we've seen from the recommendations that they should use hormone therapy at least until the average age of menopause or usual age of menopause. In the West, it's 51 years of age. But there is some discussion and debate at the moment as to whether they would derive additional benefits from continuing their hormone therapy into their 50s and even later in order to protect the heart, the bones, the brain. And in fact, we're currently writing a position paper with FIGO to say we need further research in this population and to identify the research questions that we then want to be able to perform that research and provide more data. But in the absence of good data, what we normally say is look at the individual as a whole. What are her ongoing risks of cardiovascular disease, of osteoporosis, of dementia, etc., etc., and take all of that into account, as well as her quality of life. If she does want to stop hormone therapy, reduce the dose gradually. Yes, don't stop it immediately. She's less likely to have rebound symptoms. For women with menopause at the usual age, the societies, the Menopause Society, is very clear in their guidance that we don't put arbitrary limits on duration of use of hormone therapy. That again, it should be individualized, carefully weighing up the pros and cons of continuing hormone therapy in that individual and taking into account quality of life and other risk factors. So we mustn't forget that menopause symptoms can last on average 8 to 10 years. So it's not surprising that women who are taken off hormone therapy, even sometimes in their early 60s, have a recurrence of symptoms. Of course, if we are continuing the hormone therapy into a woman's 60s and 70s, we need to review the route of administration, the dosage. As they get older, they have a higher risk of VTE, venous thromboembolism, and stroke. So we may wish to switch them to a transdermal preparation, use more metabolically friendly types of progestogens, so micronized progesterone, for instance, and tailor make it to their requirements. But don't give them a definite time limit. It needs to be decided on her individual quality of life and risk factors. Oh, and just to add, also very important that however long she continues with the hormone therapy, we must continue with her breast screening as well. There are, in some countries, breast screening may stop at 65 or 70. If she's using hormone therapy even later, she should continue with her mammography, of course, to ensure that all is well, and taking into account whatever risk factors she has from that perspective.
Thank you. We thank you profoundly, dear Professor Panay, for being with us today and for this unique opportunity to find out firsthand about the updated clinical guidance on POI. Thank you very much for answering our questions. I have a lot of thank you on this chat. Let's hope that we will meet again and we will continue our joint work as part of the IMS. Thank you very much from our audience and from my team as well. Thank you.
Спасибо большое, Antonina. And to everybody.